We can see that.
Okay, and we've got, and are we recording? We're recording? Yeah, we're recording. See? Yep. I think we are. Right, cool. Okay. All right, tēnā koutou katoa. Welcome to this bioethics seminar. I'm Josephine Johnson. I'm one of the lecturers here, and it's my pleasure to introduce my colleague, Taryn Knox. So Dr. Knox is a lecturer here in the Bioethics Centre, and she's going to talk about BMI and whether it should be used in a clinical setting. So the way we'll run it is that Taryn will make her presentation, and then we'll have time for questions. So people online, if you keep yourself muted for the duration of the presentation, and then use the either raise hand function or your actual hand, and I will make sure I keep an eye on who's online wants to ask a question, and then the room will also take questions. Is there anything else that I need to
I feel like I'm sort of at the facing.
Yeah, the room is just a little bit different for us here today because we're in the middle of moving, so not moving completely, but moving things around. So do you want to?
So
Are you
apologize.
for?
Yeah, so I am sort of I can't face both of you.
Right. Yeah, we've just got a little bit of a different setup.
But that's okay. That's okay. Kia ora koutou. Thank you for coming. So I was originally ready to give this talk just over 2 years ago. When I was pregnant, and then I nipped over to Queen Mary for a routine appointment and ended up in hospital. So it's taken, and our journey just had her second birthday on Monday, so it's taken nearly 2 years to get this up and running again. But I feel it's much better. 2 years has been beneficial for me.
Sorry, I skipped a bit.
That's fine. So I'm going to talk about BMI and some of the problems with it. I don't think I'm extreme. I'm not going to come to the conclusion that BMI is rubbish and we should get rid of it, which is the conclusion that some scholars have come to. They've said things like, our analysis is the final nail in the coffin for BMI, and we should have a requiem for BMI. Now, those are nice sort of emotive titles, but I'm not as extreme as that. So hopefully that my sort of more measured account will come through. So I'm sure you all know what BMI is, body mass index, but I'll tell you a little bit about the history. So in 1830, was the Belgian guy Quetelet. He wanted to work out what the average man was. That was for religious reasons. He thought that if he could work out the average, that would be what God wanted as the ideal. So that's where that came from. Quetelet looked exclusively at white men. So it's one little problem there. In 1867, it began to be used by life insurance companies, so to figure out who was more at risk of dying and then having to pay out. In the 1970s, Ansel Keys and his team formalized Quetelet's ideas into what we now know as BMI, and it was adopted by the WHO in 1995. So now we know that BMI is widely used. We come across it in all sorts of healthcare situations. And basically, weight divided by height, and it's supposed to tell you how much fat, or the level of obesity or adiposity. Now, it's not perfect. No one says it's perfect, but it's supposed to be a reasonably good proxy for the amount of adiposity a person has. Loads of problems with it. Some of them I'm not going to discuss today, just because I don't have time. One is whether obesity is a disease. I don't think it is, but I'm not going to get into it today. There's been a change in cutoff points. So underweight used to be under 20, and now it's moved down to 18.5. There's also arguments that cutoff points should be changed for different ethnicities. Māori and Pacifica, they might, a higher BMI might be healthier for them. Interestingly, the latest guidelines from the Ministry of Health said they're not going to do that. So they're not going to increase a healthy BMI for Māori and Pacifica. But they did recommend lowering the healthy cutoff points for Asian people. So I don't know what you think about that, but I'm not going to talk about it too much. And also the names. So normal weight. Most, statistically, it's not statistically, most people in New Zealand and around the world are in the overweight. So I think what they mean by normal weight, or what they want to mean, is something more like healthy weight. I'm not going to talk about those problems today. So if a lay person Googles BMI, they'll calculate their BMI and then they'll find something like this graph. And it shows that if you have a normal or a healthy BMI, so in that range from 20 to 25, or 18.5 to 25, you've got the lowest health risk. And your health risk increases as does your BMI. That's the conventional, that's what everyone thinks about it. Same goes for underweight people. Their health risk increases, but that's not my focus for today. So the very general view amongst lay people and amongst health professionals to a large extent is that there's a fairly solid relationship between BMI and health. The higher your BMI gets, the higher your chance of being in health. So here's my very simple Philosophy 101 syllogism, basically saying using BMI is harmful, so we should be wary of it. So the title of my presentation is, should we be using it? Here I sort of dial it back a bit and say, should we be wary of it? I think there are 3 ways in which using BMI is harmful. I think it's a poor measure of adiposity. So before I talked about it being a proxy, it's not perfect. Well, I think it's too imperfect to be used. Then we're going to look at the relationship between BMI and poor health. And there's quite a lot of data to show that actually, although we have this narrative that there's a strong relationship, it's not actually that strong. And then finally, I'm going to talk about weight stigma. So the first harm about the measure of adiposity. This is really well known, so I'm just going to flick through it really quickly. So there are 3 points to this. BMI is a really poor calculation of the amount of fat that someone has, because it conflates fat and muscle. So when you step on the scales just give you weight. It doesn't say how much of this is fat and how much is muscle. So the typical example is of an All Black, who will probably end up with an overweight or obese BMI because of their high muscle content. The opposite is sarcopenia, when someone has a high fat content but a low muscle content. And so they'll come out as being within a healthy BMI, although they have a lot of fat. Sarcopenia often happens in frail people, elderly, that sort of thing. Something to be worried about there. It's not only the amount of fat, it doesn't measure the fat distribution. So there we've got android obesity, so fat around your belly, or gynoid obesity, fat around the hips. And having fat around your belly is much more dangerous than having fat around the hips. So BMI doesn't count for that. Thirdly, the type of fat matters. So we've got subcutaneous fat, which is just under the skin, not as dangerous as visceral fat, which is around the organ. The BMI doesn't account for the amount, the distribution, or the type of fat. So it's not a good measure of the amount of adiposity an individual has. Okay. There are better measures, there are better ways of doing it, like having DEXA scans, but those also have disadvantages. So they're they're relatively costly, they're more time consuming. So, you know, BMI is super easy to calculate. Do it and, you know. So that's why I think one reason why BMI continues to be used, even though we know it's not really good, it's just so convenient. Right, so that's the first problem very quickly. Let's move on to the second. So here's the graph that you saw before. And so from this sort of graph, we think, okay, normal, healthy BMI, lowest risk. But in 2013, there was this big study done, with a big meta-study done by Flegel and her colleagues. I think there were, how many people? More than 1 million data points there. So they looked at a huge amount of people. And they found that actually being in the overweight or type 1 obesity category gives you the lowest risk. So essentially there's that J curve there that just moves over, it just shifts to the right a wee bit. They also found that people who are in the type 2 and 3 obesity categories, they still are at very high risk, you know? So their risk still increases. There's still a relationship, but it's just shifted over a wee bit. And interestingly, both John and Neil came to me this morning and told me about this study, published last week. It basically came to the same conclusion as Flegel. So they had 500,000 data points, and they found that the lowest risk is in here. So in that 25 to 27.5, which is in the overweight. It's the first half of that overweight category. So a lot of people have problems with this, and no, I accept there are problems. Boyd Swinburne was on RNZ talking about, okay, well, that's for mortality, but we need to sort of be more specific than that. So for specific diseases like diabetes, there's still a really strong relationship. So that, you know, it's not the be all and end all, but studies like these should at least make us start to question why we are so wedded to BMI. So we've talked about the obesity paradox. Now we're going to talk about metabolically healthy obesity. This is taken from a study from Tomiyama and her colleagues, Janet Tomiyama. So they did this study, and they found out that 30% of normal weight people are metabolically. So, you know, they're at much higher risk of dying. And then, sorry, they're not much, they're at a higher risk of dying if you're metabolically unhealthy. And it goes up as your BMI goes. Okay, so there is a relationship. That's quite clear. Okay, but let's look at this in a little bit more detail. If 30% of people of normal weight are metabolically unhealthy, and we only use BMI to screen for metabolic poor health, you're missing out, you know, nearly a third of people. Again, if we look at this overweight category, 53%. That's not much better than flipping a coin. You know, that means that there's a whole, you know, 47% who aren't going to be metabolically unhealthy. So if we take this population data and then apply it to the individual in a clinic and say, oh, well, you know, you're unhealthy because you've got a high BMI, you know, you've only got a 50-50 chance of that being correct. Now, I'm not saying that that's what doctors do. In practice, I think you have to be much more nuanced than that. But some of my research has shown that whatever doctors do in practice, that's not what is recommended by the guidelines. So guidelines are very, very focused on BMI, and while they do look at other factors, they come in after the fact. And so the other point is that, well, just because they're correlated doesn't mean there's a causal connection there, and that should be very clear to all of us. There is evidence of causation for some diseases like osteoarthritis and cancers impacted by estrogen, but in a more general sense, we're unclear about causality. So what factors might be at play? Why are some overweight people metabolically healthy, and why are some normal weight people not metabolically healthy? Here's a list of things. High BMI. Some people say it does matter, some people say it doesn't. I think it's plausible that it will have some impact, but I don't think it's the only thing. Heritability. So to metabolic poor health, there's a huge genetic component. Other factors include diet, activity, weight cycling, so your weight going up and down, actually been shown that, you know, people who gain and lose large amounts of weight, that's more unhealthy or more risky than someone who's just been, you know, obese their whole life or their whole adult life. And there's also weight stigma. I'm going to look at weight stigma soon, but first I want to show you that physical activity. So we've got the blue dot there, which says a fit person, and the red triangle is unfit. So we can see here that being fit reduces your hazard ratio, and this is of cardiovascular death, regardless of your BMI. We can also see that the hazard ratio for fit obese people is less than the hazard rate of unfit normal weight people. So 1.6 versus 3.1. That means obviously a fit obese person is healthier, has less risk than an unfit normal weight person. And if we look again, the hazard ratio for fit obese people isn't that much higher than the hazard ratio for fit normal weight people. So we're going from a baseline of 1 just up to 1.6. There's an increase for sure, but it's not a huge increase. So physical fitness has a huge impact on health, regardless of one's BMI. So to summarize, when studies control for these factors, the relationship or the association between BMI and metabolic disease significantly reduces. It's still there, but it's much smaller than we normally think. However, this doesn't occur for people with type 2 and 3 obesity. So those people with a BMI of over 35, off the top of my head. So the obesity paradox suggests that being of a higher weight isn't, in the overweight category, isn't as risky as we might have thought. And there are lots of other processes that mitigate or mediate this relationship between high BMI and poor health. So using BMI could be harmful insofar as it leads to false positives and negatives. So false positives for the larger person, when the doctor says, oh, you're overweight, you're more, you're unhealthy. But also false negatives for the person of normal weight, when the doctor assumes that they're healthy based on their BMI. You can see from that list that weight stigma is listed there. So it's not only physical processes that impact on health, it's also psychosocial processes, weight stigma being one of them. So the idea is that, okay, it's not solely high BMI that that impacts on a person's health. It's also stigma. So if you are stigmatized about your weight, that can contribute in itself to having poor health. Let's have a look at stigma in a little more detail. Here's a very brief definition of weight stigma: negative attitudes and beliefs that manifest as stereotypes, rejection, prejudice, discrimination towards larger people. Quite straightforward to me. Here's I think a quite shocking example of weight stigma. This was a campaign somewhere in the US in the 2000s that came about. You can imagine how, if you were the fat kid at school and you see that poster on a billboard going to school, how you would feel. Or if you were the parent, of that fat kid. Yeah. So in the recent past, so obviously the proponents of things like this thought that stigmatizing weight could actually be helpful because it encourages people to lose weight and they'll be healthy. There's very strong evidence to show that that doesn't work. It is harmful. And, I think we can look at that and think, oh, that's terrible. That should never have happened. But I think, well, I know I do. I stigmatize smoking in that way. And so you need to be careful about, thinking, oh, we're so good, I would never stigmatize someone like that. I know I stigmatize smokers all the time. So, and I think, oh, by sort of shunning them, they're not going to smoke anymore. Well, I think I'm wrong on that front. Right, so settings of weight stigma, basically everywhere. Employment, education, you're less likely to get a high-paid job, or in the US, you get admitted to like a highly ranked university. Interpersonal relationships, media, everywhere in the media, and there's internalized stigma as well. So that's when you take it on board for yourself and think that you must be a terrible person because you are overweight. And then there's healthcare, and we think that, okay, healthcare should be this welcoming place where people are able to come and, without judgment. That's not the case. Health professionals have a very high level of weight stigma. And it's across the range. It doesn't sort of matter what sort of health professional you are, from a psychologist to a dietitian, although there are different levels of weight stigma. It's found across the board. And forms of weight stigma. So there's heaps, basically. There can also be what you might think is positive, can be a microaggression. So you could say to someone, oh, you look great, have you lost weight? That can be a microaggression because the person thinks, well, what was wrong with me beforehand, okay? So my wonder, well, I'm sitting here thinking about BMI. I don't think that it's teasing, bullying. It might be pressure to lose weight, but I'm wondering whether a clinician using BMI in the clinical setting is a microaggression. There's a definition of microaggression. An important thing about microaggressions, but I'm not going to get into too much into it today, is that they're most often unintentional. So you're not intending to send this horrible message to someone. So intention is irrelevant. What's necessary is that the person experiences it as being degrading. And there's a lot of research on microaggressions and a lot of people problematizing it, and that's one of them. We can talk about problems with the concept of microaggressions later, if you'd like, but I'm not going to look at that today. I'm going to look at whether BMI is a microaggression. There's been no empirical research on this, as far as I can tell. There's been some stuff that's kind of similar, but nothing that really hits the nail on the head. And, you know, I don't want to presume that it is a microaggression. I do think we need to do the empirical research and we need to actually talk to people. But I think that it's at least plausible. So here's a scenario. Just realized that I've just been talking to Molly this morning about how I'm so tired and I'm going to go and get a blood test about my iron levels, and now my examples just is exactly the same as this. Never mind. So Jane goes to the GP complaining of tiredness and fatigue. The GP takes a sleep history and suggests that she gets a blood test to check her iron levels. He asks about her mood and considers lifestyle factors such as diet, exercise, caffeine intake, and general sleep hygiene. And the GP asks to weigh Jane. Jane agrees to that, and he calculates her BMI, and she's in the obese category. And then the GP says to Jane, look, if you were to lose some weight, you might not feel so tired all the time. I think that Jane, or it's plausible that someone in that situation could find that degrading. They've talked about all this other stuff, but then when it comes down to it, the GP is giving advice about her weight and her weight loss and saying, this is the problem. The GP might be right, for all we know, but that's not what matters here. What matters is how Jane experiences that. And so I think she might think that the GP is sort of rubbing her nose in the fact that she's larger. Moreover, given the predominant narrative that having a high BMI is unhealthy, then she's more likely to see it that way. Okay? So the structure or the background setting is relevant to whether something is experienced as a microaggression. So this is not a very sophisticated argument. It's just, I think that someone in that situation might find that degrading, might find it to be a microaggression. I think it's plausible. Okay, so what are some counter arguments to that? Newton says, well, it's just a number. It's just a calculation. How can it be stigmatizing? And this is partly my argument and partly Guten's argument, but I say BMI isn't just a number. It's become imbued with meaning. There's this, this widespread feeling that if you've got a high BMI, you have poor health. It's just not just a number. So I think, well, just that's incorrect. So therefore, it can be a microaggression. And then Guten would say, okay, well, let's just strip back the meaning. Okay, let's just bring it back to bare bones, and we can take account of all those studies that I talked about before, and so that it doesn't have this big overinflated meaning, and then it becomes just a number. Fine, in theory, but in practice, good luck. I don't see that in my lifetime ever changing, given the entrenchment of diet and weight culture around the world. So it's not just in Western Western world, it's everywhere. I think it's going to be impossible to change the meaning of BMI. So I still think that using BMI is a microaggression. So if we can't change the meaning of BMI in the short term, could we perhaps use it in a way that is less stigmatizing? And this relates to Guten's idea that to say, is using BMI in the clinic stigmatizing, is the wrong question to ask. He thinks we should say, is the specific way in which it's used stigmatizing? And so I gave this talk a few weeks ago to the Department of Surgical Sciences, and questions that came up were all very much like, well, we agree with the evidence that you've shown us in the previous section. We don't really want to talk about BMI, but sometimes we just have to, because it's what the hospital policies require us to do. And so what do you recommend? How can we do it in a way that's less stigmatizing? And so here are some potential answers to them. You could clarify the problems. So basically saying, look, it's not a perfect measure. There are difficulties with it. You could talk to them about how you're aware that they could be feeling stigmatized. You could reflect on your own internal weight stigma. So even though you think, actually, I'm not being stigmatized, there are many ways in which you might be. And this one is, I think, possibly the most important. So don't consider BMI before these other things. So don't give it temporal priority. And this is where I think the Ministry of Health guidelines go wrong. So they've got their clinical guidelines for weight management, and in that they say, take someone's BMI. If their BMI is in the healthy range, cool, just monitor it. Okay? If your BMI is in the overweight or obese range, then you start asking all these questions about diet, health, you do that bigger history. But that's giving it more importance than it deserves. So it's giving it temporal priority because you're putting it first, but it's also giving it what I've been calling magnitude priority. So it's making it the most important thing. I think that's wrong. I think they should be done, if you're going to use BMI, you should be using it in tandem and not overinflating its importance. So the focus of this presentation was to think about how using BMI in the clinic might be harmful. I've said it's a poor measure of how much fat someone has, so it can lead to false positives and negatives. The relationship isn't very strong. Well, it's there's still a relationship there. I don't doubt that. Again, that could be harmful because it can lead to false positives and negatives. And also using BMI might be a form of weight stigma, and weight stigma isn't necessarily harmful. So you might be thinking, well, why on earth are we still using it? And I've said, it's entrenched in our society. It's going to be very difficult to stop using it. I think it's going to take a paradigm shift to deflate the importance of BMI. And I think it's really difficult to do, to change the meaning of something like that. Another reason is there are many positives to using BMI, which I mentioned very briefly before. Here we go. Simple and cost effective to calculate. You can do it at home. It doesn't cost anything apart from the cost of some scales, doesn't rely on self-reporting, which, you know, diet and exercise do, you know, in most cases. And we all over-exaggerate how much exercise we do and how little chocolate we eat. Right? So self-reporting is just as problematic, or it's problematic, but in different ways. There's no risk to the individual. There is a relationship. It's easy for patients to understand. And there's some debate about this, but the general idea is it's much easier to understand a simple figure in that graph than the other staging systems that have been postulated. Oh, I've got 4 and 7 twice. That's okay. And then some people say, well, you know, we've had it for such a long time. We've been using it. Let's just keep on using it. I mean, yes, there's some argument for that, but if it's a flawed measure in the first place, why would you keep on using it? But, you know, these are some reasons why we continue to use BMI. So my conclusion basically is, if there's a less problematic, if there's a less problematic something that's less problematic than BMI, then we should use that. I don't think there is at this stage. So if we are going to use it, we need to use it in a nuanced way that accounts for the limitations and potential stigma. So should BMI be used in the clinic? I'm not sure. I think maybe, but if we're going to do it, we should do it in a nuanced way. We need to be aware of the limitations and the potential for stigma. And that's all I have for today. So thank you.
Thank you, Taryn. I'm just going to take do you want to maybe stop sharing, or do you think you need your slides as part of it? Okay, so we'll stop that. And then we'll just,
unless someone wants to refer to it, then we can get them back up.
Yeah, sure. And here we have I think everyone who's on. So, and then we've got a question in the chat as well. So we could take the first question from the chat if you like.
Yep, sure. So the first question is, what was the original graph showing the relationship of BMI to health based on? Later research has moved the curve to the right, but what decided why it went where it originally did? Was there some evidence, or was there some form of a priori presumption? I don't know. I guess there was some evidence. It would seem silly that there wasn't. But even if there was evidence, I suspect that that evidence was skewed by, you know, people's intuitions that being overweight must be unhealthy. So sorry, Neil, doesn't really answer your question.
Does anyone else online have a question? Oh, here's another one. And we can ask a question.
The question, both healthy and normal carry value connotations. Can we reframe any categories of weight as value neutral to help avoid weight stigma, or is that language too entrenched? So I think that would be I think that would be a good step, but it's not I don't think it's definitely not going to solve the problem. And so we shouldn't be tokenistic about it. So we shouldn't think, oh, well, we've solved the problem of weight stigma by renaming things, because it just wouldn't work. We would have this, the new terminology would become value laden in the way that the old one was. But in saying that, I think we should change those names, because they're value laden and they're not accurate as well.
Yeah, hey, Taryn. Thank you for a really fascinating talk. It's really interesting. I literally just come from talking to third year medical students about this exact thing. And so I had two kind of questions, comments. One was, seeing some evidence that using waist circumference and different measures there might be more accurate, and again, quite an easy thing to do in the clinic. So I want to hear your thoughts on that. And secondly, the idea that the Ministry of Health, didn't want to change the ranges for different ethnicities, and there's evidence to show that we're overestimating obesity with, as you say, Māori and Pacifica, and underestimating it with Asian populations. I just wanted to hear what the reasons why the Ministry of Health decided that.
So I don't know. I suspect there are political war. They don't want to rock the boat and offend people. But then why do it for Asian populations? I don't know. Does anyone else have any insight into that? I think this idea that, everyone in the world is the same, we're all one people, plays into it. And you'd have to be a brave person to step up and say, well, actually, that's not the case. We are different. That's my intuition. Yeah.
I'm just interested because you talked about we need a paradigm shift, and what that's going to look like, because I'm thinking, it perhaps does need to shift, because there has been such a dominant and an invested interest in keeping BMI. And I suppose where I work with a lot of young people, I think about the bigger questions of understanding the why we would be continuing to use it, why young people are presenting maybe looking overweight to normal, which raises, of course, the bigger picture around the context of people's lives. So maybe that's too uncomfortable for some people. I don't know.
Yeah, so I think that we can very much blame the individual person when really, we live in an obesogenic environment. There's no doubt about it. And you look at parts of Dunedin. I like South Dunedin, a more deprived area. There's very little green space there for kids to go and play. There's lots of fast food there, compared to other areas. And so, I totally think we shouldn't be blaming the individual. We should be looking at societal reasons as well. However, I do think the individual has some role to play. And I do think that there's some value in that positivity movement. But just to think that you don't have to look after yourself and you can go and do whatever you want, I think that's just as dangerous. I think, having that type 2 or 3 obesity and either saying, oh, it's okay, it's just the way I am, or, well, it's society's problem because I live in this deprived area, that's not okay either. What was your first question, Sarah?
About whether using waist circumference and all those kind of things.
Yeah. So I think, even the Ministry of Health have said, that is beneficial. They should be done together. That does give a better measurement. I don't think it impacts on weight stigma at all. And I also think, well, I've never had my waist circumference measured where I've been. And that to me suggests that it's just too difficult a topic for GPs especially to discuss. It's just super sensitive and they just think, okay, well, we just won't go there. Yeah, but definitely it's an improvement by doing both. Yeah.
So you have, I'm not sure why we can't see all the people on screen because there are actually 26 participants.
Oh, wow.
But in any case, there are a few more questions here. Let me see. Did we do this one about value? Yeah, we did. Okay, this one here is about, I can read it if you like. I'm curious about your thoughts on using simple weight in a GP clinical context. As you mentioned, it's quite useful to track weight over time, both increases and decreases, as this can provide a window into medication side effects and long-term side effects, particularly in aging. Some medications are also contraindicated with elevated BMI, contraceptive pill being an example.
Yeah, so when I was talking about tracking weight over time, I was thinking more of on a population level. But I guess it could be, there could be certain benefits on doing it on an individual level. Although
Kia ora. That was my question. Hi. I'm in Wellington. Yeah, I guess what I was thinking of is it is such a stigmatizing and challenging conversation. And I had a really interesting, I monitor my elderly patients because I'm worried about their weight loss. So I want to keep an eye on their weight decreasing. And I checked the weight of a 73-year-old woman who was on antipsychotic medication. And I must have made some comment or face or something. And she came back and saw me 3 months later and had lost weight. And my concern had been that she had lost weight. Like, I wasn't pleased that she'd lost weight at all, but she construed my reaction as a positive, like a positive that she had. So that, I guess that's where I was, because actually weight monitoring can be quite a useful tool. Thanks.
Yeah, and I agree. I think it can be useful, and that's why we shouldn't get rid of it. But we need to be really careful about how we use it. And I think that as health professionals have a duty to make sure that whatever facial expressions or however you relate to your patients, that they actually understand where you're coming from, because otherwise it can be dangerous, like in your example where maybe this person has lost too much weight.
So there's a question also from Sumner. So I'm not sure, does that person want to speak their question, or shall I read it? Or you can unmute. Oh, I can go ahead and read it. My reading on the quintetlet. I was saying queetlet, but I asked Tania. Yeah. Kettle. Okay. Leads me to think that the logic of averaging across people is highly problematic. And I wonder if you had thoughts about the conceptual basis of that. The logic of averaging across people leads to the creation of summary statistics that are systematically biased towards the dominant group, like male white. Given these problems are evident with BMI and problems with application across categories of gender ethnicity, do you have thoughts about the use of BMI specifically in producing inequitable health outcomes?
No, I haven't thought about that, but I totally think you're correct. So if we're using BMI to access, say, ICU, that's one of the criteria that you're using, because the thought is that someone's BMI increases, they once they're very overweight, they're going to have less positive outcomes in ICU, and also it's more difficult to care for the patient, like to turn them and that sort of thing. And if Māori and Pacifica people are bigger, yes, that is going to lead to health inequities, just like the person underneath has said. So I do think so. I think it leads to health inequities. And then I also think it leads to this social stigma. But, like I said, weight stigma can impact on your health independent of your BMI. So you're bigger, which is apparently bad for your health, and then you get sent these stigmatizing messages, which just exacerbate the idea that you're unhealthy. So I think highly problematic. And then all the other sort of intersectional issues that Māori and Pacifica and other marginalised groups have faced as well.
And then there's a question from Cassie. Can you speak to the use of BMI or applying the BMI measure to children?
No, I think it's problematic. I think everyone knows it's problematic because children grow at different weights. I know that it shouldn't be used when you're pregnant for the same reason, but that it is used during pregnancy. So, yeah, I know. In the New York Times, there was a podcast about the use of BMI in children and some alternatives to that, but I can't speak to that.
Okay, great. Anything else from the room?
was just wondering, do you think like having too much of a focus on BMI in the clinic then makes people sort of, or makes clinicians maybe not focus on the positive so much of exercise, like, you know, exercise with obesity and for people of supposed normal weight is so important that you reckon that gets lost a little bit?
Yeah, I think if you, well, I don't know, but my intuition is if a normal weight person goes into the GP, they don't often get asked about how much they exercise. If I go into the GP, I do. Yeah. So, yeah, I think.
But even if you got rid of BMI, I mean, a lot of those judgments are made visually based on visual information, or however, you know, they're not based on BMI.
No.
So
yeah. So someone, I can't remember what his name is. I said if it walks like a duck and it quacks like a duck, it's a duck. You know, so if you're a big person and you go,
like, I mean, getting rid of BMI, how is that
I think
going to change the?
I think it's going to be the first step in showing that actually, if the relationship between the two isn't as strong,
Right.
So you're right. I don't think it's going to it's not going to solve the problem. But it's one step in doing so. Yeah, because if a really big person comes in, you're going to assume that they eat KFC and sit on the couch all day. So
I just think people, because we're so trained to,
exactly,
we have a conception of what's a healthy weight when we look at people, and that might be warped, right? I mean, it might be more warped than the BMI is. You know what I mean? So
I don't. It's not going to solve the problem, but I think it's a good first step. Yeah.
So I want to just respect that we said it was 1 to 150 and thank you for your presentation, but also know that you're going to stick around for a little bit. And so Andrew has another question.
Okay.
Anyone else might want to, but just before we do that, I just want to formally close and say thank Taryn for this really interesting final topic. And this is the first in our series for the second semester of these Monday seminars, and they'll just go every Monday until the end of the teaching session. So I'll see you next week. But yeah, Andrew's question.
I'll let people leave first if they need to.
Thanks, Taryn.
Thank you. So Andrew asks, has anyone developed in trial diagnosis treatment that ditches BMI altogether? I know of something that's going ahead from Hamish Osborne, but they've got a Healthcare Otago trust that measures things like VO2 max, like your lung capacity. It measures a range of things. And that's, according to him, is a really good alternative to BMI. And I just need to scroll up. So the second question was the use of waist circumference and android fat, which is fat around the tummy, versus gynoid fat around the hips. And Andrews asks, won't that exaggerate the health troubles of females? That to me seems intuitively correct, but no one in the sort of literature has mentioned that as a problem. So I can't answer it. Is there any health professional out there who knows more about this? What is gynoid fat for men? I don't know.
So can I just say briefly to it? I just thought I'd heard somewhere some studies on that carrying weight round the middle, kind of pot belly type thing, is more characteristic of male carriage of fat and the kind of round the bottom and the upper thighs kind of thing is a bit more common in female bodies. And you seem to be suggesting that, and I think there's, as far as I know, there's evidence of this as well, that the kind of hips and bottom carriage is kind of less troublesome in health contexts than the kind of male pot belly.
Yeah.
Just to put it in itself rather stigmatizing sort of gender terms or sex terms.
Yeah. Yeah, so just the evidence is that, you know, you got the big, so if you're an apple shape, that's more dangerous than if you're a pear shape, although there's loads of problems with those using those shape analogies as well. Yeah.
I don't think there's anything else except people saying thank you.
Oh, great. All right. Thanks for coming, everyone. I've really appreciated the opportunity and the feedback that I've got. So watch the space.
Thanks,
Right.
Taryn.
Thank you.